Hi everybody, thanks for tuning into this quick video on the fascia iliaca plain block. Both the femoral nerve and the lateral femoral cutaneous nerves lay under the fascia iliaca, and so we aim to inject a large volume of anesthetic that will diffuse to these nerves. We also aim to hit some of the articular fibers from the femoral nerve that go to the hip joint. However, this block does not routinely hit the obturator nerve, and so will not typically result in complete anesthesia of the hip joint or the medial part of the thigh. Because of this block is most useful for fractures of the proximal femur, most of which we call hip fractures, even though the hip joint itself is not routinely anesthetized. We can expect cutaneous anesthesia of the lateral and anterior thigh as well as the medial lower extremity. It's worth noting that distal motor and sensory function should be preserved given that this comes from the sciatic nerve more posteriorly. For this block, the operator is going to stand on the affected side of the patient and they'll face the contralateral side where they have placed the ultrasound machine. The needle is going to enter in plane, lateral to medial as demonstrated in this image. The anatomy of this block is pretty straightforward. First, identify your femoral artery and vein as you would for a femoral central or arterial line. Then you're going to slide the probe laterally and you will see the femoral nerve and then the iliopsoas muscle. The fascia iliaca is the fascial plane that lays on top of the iliopsoas and separates it from sartorius more superficially. Since this is a plain block, we're aiming our needle for a potential space, in this case the potential space between the fascia iliaca and the iliopsoas. In this image you can see our block needle entering from lateral to medial from the top left of the screen. With this block we don't need to go anywhere near the artery or nerve, which decreases our risk for last and peripheral nerve injury. As the needle advances, you see it deform the fascia iliaca and ends up requiring a fair amount of pressure to pop through this fascial plane. This is because these needles are blunted to decrease the risk of damage to other structures. The pop is fairly obvious to the operator. By the time the needle does pop through, the tip advances into the iliopsoas muscle, so it's then drawn back to get into the potential space just under the fascia and not within the muscle. Interestingly, this block has long been performed without the use of an ultrasound. The fascia lata is a fascial plane that sits on top of sartorius, and so the operator would advance the needle until they feel two pops, at which point they would know that they were under the fascia iliaca. Even when using an ultrasound, these two pops are usually something that you can feel as the needle advances. As our anesthetic is injected, you will notice a small amount ends up above the fascia iliaca, and so the needle is minimally advanced until the entire bevel is under the fascia, and then we see all of our anesthetic under the fascia as we had intended. It's fairly common to have some spillage around and above the fascial plane until you're able to hydrodissect that fascia off the muscle and create the space for your needle to sit. At this point, basically you're going to continue to inject, drawing back every 5 cc's or so to ensure that you've not migrated into a vessel. Our target volume for this block is 30 to 40 cc's of total volume. Depending on your calculated maximum dose, you may need to add some saline to your anesthetic to get the volume that you are shooting for.